Thank you. Ladies and gentlemen, VinFuture Foundation is an independent, not-for-profit foundation in Vietnam with a mission to build a great future where breakthrough scientific research and technological innovations empower people, positively enhance their lives, and create a more equitable and sustainable world for the coming generations. Starting from September until the end of this year, our foundation is organizing a monthly public dialogue series to promote science and technology and their impacts for humanity, especially in addressing the 17 Sustainable Development Goals of the United Nations. And today in September, we are focusing on goals number 3, good health and well-being. With that, it is my distinct honor to introduce to you the distinguished guests of today's section. I am privileged to introduce to you Professor Zeke Emanuel, Vice Provost for Global Initiatives, University of Pennsylvania from the US. Professor Emanuel is a special advisor to the Director General of the World Health Organization. He also served on President Biden's Coronavirus Advisory Board and also former health policy advisors under the Obama administration. Professor Alta Schutte, Principal Theme Lead of Cardiac, Vascular, and Metabolic Medicine in the Faculty of Medicine and Health at the University of New South Wales, Australia. Professor Schutte is also a professional fellow of the George Institute for Global Health. And from the VinFuture Foundation, I am pleased to introduce to you Dr. Lê Mai Lan, Vice Chairperson of Vingroup and designated representative of the VinFuture Foundation from Vietnam. And the discussion about how science is transforming global health will be moderated by Associate Professor Linh, Vice Dean of the College of Health Sciences at VinUniversity Vietnam. I'd like to welcome all of you, all the attendants and audience who are joining us from different countries, regardless of different time zones, in this Zoom meeting, as well as those of you who are joining us via different live stream channels. Thank you very much for your time and for your participation. And to start the dialogue today, I'd like to invite Dr. Lê Mai Lan, designated representative of the Foundation, to deliver her welcoming remarks. Please, Dr. Mai Lan, thank you.
Good morning, good afternoon, good evening. My name is Mai Lan. I'm the designated representative of VinFuture Foundation. I'm also the Vice Chairwoman of Vingroup and the President of VinUniversity. First of all, I would like to thank you all for spending your precious time with us today and welcome to the VinFuture Public Dialogue, How is Science Transforming Global Health? It is my honor to thank you, our distinguished speakers, Professor Zeke Emanuel and Professor Alta Schutte. Let me share a few words about the foundation. VinFuture Foundation is an independent not-for-profit foundation. The foundation was established with the vision of creating meaningful change in the everyday life of millions of people by honoring transformational, proven breakthrough technological innovations and research. The foundation was set up with an initial endowment of $100 million from Mr. Pham Nhiet Vuong, the chairman of Vingroup, and his wife, Madame Phạm Thu Hương. Vingroup is the largest private corporation in Vietnam and one of the top 2,000 largest corporations in the world. And I would like also to share key activities of the foundation. The core activity of us is to award the annual VinFuture Prize. Each year, we intend to award one grand prize worth of 3 million and 3 special prizes for female innovators from developing countries, and innovators with outstanding achievement in emerging fields, and each of the special prize is worth of $500,000 US. In addition to the annual prize, we also organize a number of other activities, such as grant making, partnership with research institute, university, and corporation to advocate for STEM, and organize public outreach activities, public dialogue series, like the session today. And through this session, we would like to inspire and engage people from all over the world, especially young scientists, students, and anyone who are passionate about changing the world through science, through technology and innovation. We hope you will be inspired by leading specialists to think, and more important, to take action, to act together and contribute for a better world and betterment of life of people. With that remarks, I wish you all best health, happiness, and having a very effective session today. Thank you.
Yeah, thank you very much, Dr. Mailan, for your remarks. And now I'd like to invite Professor Linh to moderate the section on how science is transforming global health. Please, Dr. Linh, thank you.
Thank you, Ms. Hạnh. Good morning and good evening. It is my great honor to serve as the moderator for our panel discussion today. We will have two great speakers, Professor Emanuel and Professor Schutte, and each of them will spend about 8 minutes for their remarks and presentations. And then we will spend the rest of our time for the panel discussion and Q&A with the audience. So during the two presentations, I would suggest that our guests and our audience take notes and prepare their questions, then they can ask during the panel discussion and Q&A. Now, please join me to warmly welcome Professor Emanuel from University of Pennsylvania, who will talk about the roles of science in the battles against COVID-19. And thank you. Please, Professor Emanuel.
Thank you, and thanks to the VinFuture Foundation for inviting me to talk and for the collaboration between the University of Pennsylvania and the university, the VinUniversity there in Vietnam. I want to talk about science and COVID, and I want to highlight two countries where it's quite clear that research and development have led to breakthroughs in our battle against COVID. Now, one is the United States, where for many years and decades now, we have had a heavy investment in basic science research through the NIH that has created also an ecosystem that includes drug and pharmaceutical companies, small biotech companies, venture capitalists, all trying to do research, make breakthroughs, and create drugs. The investigation into creating an mRNA vaccine really began many decades ago, at least 3 decades ago, when people understood mRNA could be a therapeutic intervention, but it caused too much inflation. Through a lot of research, especially at the University of Pennsylvania, it was figured out how we could decrease that inflammation and then begin using mRNA in various therapeutic ways. Beginning in about 2010, it was then thought that it could be utilized to create a vaccine, but only until COVID was it actually transformed into a vaccine in record time, around 10 months. That innovation didn't come out of nowhere. It came on the basis of this important ecosystem involving academia, other researchers, companies, venture capitalists, regulators. That ecosystem grew up over decades and was able to rapidly make progress when the situation occurred. That led to 2 tremendous vaccines that we're all now trying to get to the world and trying to distribute manufacturing capacity around the world so that we can make enough vaccine to immunize 7.8 billion people in the world. The second innovation looks at the UK, at Britain. In COVID, Britain has had remarkable success in investigating therapeutics, both showing which therapeutics work and the therapeutics that don't work. And that also rested on decades of establishing an infrastructure for conducting large, simple, randomized controlled trials. That infrastructure began being constructed in the 1980s around cardiac disease. It was a national infrastructure, actually an international infrastructure, with a lot of British scientists trained in how to conduct these large trials, putting lots of centers together. And the British, within 100 days of COVID beginning to show in the country, was able to prove the effectiveness of cortisone and steroids, was able to prove that hydroxychloroquine was not effective, and many other interventions not that effective. It was their capacity and their decades of investment in being able to conduct these large, simple, randomized trials that allowed the British to really provide information to the world about which interventions work and which interventions don't work. From these two cases, I think the lessons are pretty clear. We can have science benefit the world when we have disasters like the COVID pandemic. But science can only work when it's built on a pre-existing foundation that is developed over years and decades. You need a foundation of research facilities. You need researchers who have training and have done that. You need companies that can actually develop the research breakthroughs. And all of this takes time. So if Vietnam or any other country wants to become a leader, it will take decades to establish the right infrastructure. But if you don't invest now, you will not have a robust infrastructure in the biomedical areas 2 or 3 decades from now. And that's, I think, the key message of these historical examples during COVID, that we bear the fruits, but the fruits have been a result of plants being created or planted many, many decades before. It takes several generations to be able to bring together all the necessary ingredients for scientific breakthroughs around something like COVID or any other major illness. Thank you very much, and I look forward to the discussion.
Thank you so much, Professor Emanuel. And now please welcome our second keynote speaker, Professor Schutte from Universities of New South Wales. She's going to talk about the need for innovations in healthcare for global impact.
Excellent, thank you very much, and great to actually follow on from this excellent few points by Dr. Emanuel. I hope you can see my screen. I've just shared my screen, and so I'm zooming out a little bit. And that is to really reflect a bit on the past 50 years or so. So as you would know, the moon landing was a massive event that took place 50 years ago, but that really changed the way we think about many things, and it really leveraged a lot of new innovations that we see today impacting health. So when the moon landing took place, there was no email, there was no internet, there was no webinars like we have today, and it really changed life on Earth dramatically and also impacted medical sciences. It was the spark for several new medical technologies such as dialysis machines, digital imaging technology, etc. So I think we need to think about this sort of development as a new spark, and really helped us to be where we are today. But when we look at the global map, and I'm going to use a few maps today to demonstrate what I want to convey to you, is the world isn't equal. It also follows on from the previous discussion that we have our high income countries, we have our low middle income regions in red and orange. And unfortunately, this inequality in terms of development and income really has a major impact on the health within these different regions. If we look 20 years ago at mobile phone subscriptions in the world, indeed, this discrepancy is clearly demonstrated. And it's also clear, for example, here in this low and middle income regions that we often see the same sort of picture. However, the past 20 years has changed dramatically in terms of the access to mobile phones. And we know that the potential value that this sort of technology, which is something small and everyone can carry in their hands, and the potential that it unlocks in terms of healthcare. We know about thousands of mobile phone apps being developed and now being able to reach people which never have been thought of before. So we know that there is this great potential, but it's not realized. And I think we need forums such as these to also try and help innovations that can impact in all regions. There are implications for health, and we need to think what they are and how best to implement that. If we look, for example, at another infectious disease, HIV, we know, again, many low and middle income countries, especially in Africa, largely affected by this infectious disease. There has been major strides forward, but no real vaccines for now. But if we look a bit broader away from infectious diseases and look at the general burden of disease reflected by disability adjusted life years, again, it is the same regions that are mostly affected, and we understand why. If we look now at the main causes of death, and this is for 2017, I can assure you it hasn't really changed much to 2021. Roughly today, I think it would be about 20 million deaths in a year are owed to cardiovascular disease, to cancers, and these are not infectious diseases. Often not so much on the radar of the typical person on the street, but hugely impactful in terms of the global burden of health. And that is independent on whether you're in a high or a low or middle income country. If we look at the COVID-19 deaths, and just for the year 2020, it was a bit under 2 million. I'm sure we have already surpassed that by this year, but it may hopefully make a downturn now that we have this massive vaccine rollout, which is a huge success globally, which show what can be done if the foundation is laid. Unfortunately, in terms of the vaccine rollout and looking at those who have received at least one dose, we still have the same challenge. We know there are many bodies and many institutions that really try and increase access and availability, but it's not only for COVID that's the problem. It's the same for cardiovascular disease, it's the same for HIV, it's the same for other diseases. And we need to think of new strategies, new innovations that can make that possible. Because data doesn't show real life settings. It's different in different areas of the world. The health systems are completely different. The availability of healthcare workforce are completely different, and we need to take cognizance of that. We are now at a new space age, a second space age, and there's a huge race to reach Mars first. And I hope, as with the moon landing, there would be similar innovation sparks that would also benefit medical technologies and innovations going forward. We've already seen fantastic developments, and I really hope it will continue on that track going forward. It can mean a lot for medicine and health. Thank you. I think I will end it there.
Thank you so much, both of our speakers. And now let's move on to the panel discussions. And I encourage the audience to type your question into the chat box. Our technical team will collect the question from both the Facebook live stream and these Zoom sessions. Due to the shortage of time, we will try to select and address as many questions as possible. So first of all, I can see that the theme technologies and science was already addressed by both of you today, Professor Emanuel and Professor Schutte. So as you said, Professor Emanuel, vaccine and therapeutic development and distribution require a massive network of scientists, biotechs and drug companies and investors, which did not happen overnight. So then what can we do better? What are the major problems still out there? Can you comment on that?
The major problems for doing better? Well, first of all, we need, I think, better monitoring around the world of potential threats. We also need, I think, more even distribution of production of medications and vaccines in particular. The mRNA and the adenovirus vaccines are complicated to produce. In the mRNA case, there are about 180 different elements you need to actually produce them. Everything from bioreactor bags to the lipid nanoparticles that they're housed in. Those are complicated to do, and they require complicated manufacturing. It's hard to set that up, 6 to 8 to 12 months. I would also say that the distribution of the fruits of technology, like vaccines, they're uneven. I do not hold, as the WHO and Gavi have suggested, that every country we ought to distribute to 20% of every country's population. In medicine, we typically distribute something in short supply based upon healthcare need, not based upon population. I like to make the analogy that if you go to an emergency room, the doctor doesn't say, all right, there are 20 people in the emergency room. I'm giving every one of you the same 3 minutes of time. In fact, they say, all right, who's the sickest here? The person with the heart attack? I'm going to focus on you first. And the same thing has to be true in COVID. We have to distribute the resources we have based upon how sick and the level of spread in the country. We know that the region suffering the most in this vaccine has not been sub-Saharan Africa, even though it has very little vaccine. In fact, it's probably been, if you look at a country, it's probably been the United States, but if you look at a region, it's probably been Latin America. And if we were to distribute scarce vaccine, countries that have high rates of COVID need to get priority. That's what equity says. And we should take our supply and make sure that those places with high rates of COVID are actually addressed. And that seems to be the most important response to me when we have this issue of equity.
Thank you. And I think I saw some questions already pop up in the chat box. So the first one I would see here is from Professor Glenn Galton, and he just asked that you, Dr. Emanuel, in the past 2 decades, we witnessed a global spread, if not origins of multiple pathogens virus, including the first SARS and MERS, and now SARS-CoV-2. And in between, we have several unrelated viruses, including the Zeke and others. So the global community sponsors monitoring efforts for influenza. So do you think that it's time to create a surveillance mechanism for virus more broadly? And if so, how might we do this, given the large number of virus classes and species?
Well, we absolutely need a better monitoring system, and we shouldn't wait for the next pandemic to come. We need it now to look at variants of interest and variants of concern around COVID. We also, as I believe Dr. Galton's question suggests, we need it for influenza. We're long overdue for an influenza pandemic. And the last thing the world needs is another pandemic shortly. And I think, this is an area where we need to have forward monitoring systems. I might note that Taiwan, after SARS, it was the country that was hit the 3rd hardest in the world in 2003 by SARS. They developed a forward monitoring system of infections in China because they thought an infection might arise in China, and they weren't sure they could trust the Chinese regarding releasing early information and information quite quickly. And they were one of the fastest countries to respond to COVID because they had a lot of advanced information from Taiwanese working in China, monitoring various chat boards. And so they, and being prepared with personal protective equipment and being willing to isolate the country. So I do think forward monitoring can make a difference, and we need more of it, that's for sure.
Yeah, thank you. So I can see that as we discussed, the theme of health equity for all pops up. And it is clear from your talk, Professor Emanuel, that you talk a lot about what we've done to fight COVID. And still, as of today, the data shows about 223 million people infected and more than 4.6 deaths globally already. So on average, 42% of the world population has received at least 1 dose of vaccines. But if you look at different countries, and it's totally different situations, less than 2% of those in the low-income countries receive at least 1 dose. And the rate is 60 or even more than 70% in Europe and in North America. So I would like to address this question to Professor Schutte. Looking at this data, and you also mentioned in your presentations, how do you define kind of like equity in these situations? First of all, at the global scale and maybe at the country level.
Yes, thank you. I think this is a major challenge to actually overcome. And I like the analogy that Dr. Emanuel has mentioned in terms of the emergency room.
Yes.
So you need to look where the problem is. For example, I've shown the slide on HIV, and at the time when HIV really became such a big issue in Africa, there was huge input from also high-income countries such as in Europe and in the US for the development of treatment. So it's not as if there is no focus on these regions. The focus is there. It is, I think, there's a role for scientists, there's a role for governments, there's a role for international bodies to really work together well. And even bodies such as the World Health Organization, United Nations, and etc., they try to really establish this, but the challenge still remains to reach those regions in an equitable fashion. And there are bodies that really only target this sort of inequity to try and make sure, for example, with the vaccine rollout, that it is indeed distributed equally. But this applies much wider, as I tried to emphasize also in the face of non-communicable diseases. And it also is very relevant that although we sometimes do have the fantastic discoveries, such as these mRNA vaccines, or in another sense also in terms of, for example, treatment for diabetes or for high blood pressure, some of these medications are very affordable, widely available, and still it's not treated effectively. So often the implementation of this, whether it's a cure, whether it's a vaccine, whether it's just medication, implementing it in a health system that works well is another challenge. And unfortunately, health system and universal healthcare, all of these facets are high priorities that many countries are trying to reach. Universal healthcare isn't something that's available in all countries, as we know. And I think there are major pushes to get that to that level, which would help the situation, but it is really not such an easy feat.
So when we go down to the country level, I think I just saw a very interesting question from the audience. During the COVID-19 pandemic, the inequalities in healthcare becomes more serious, and especially in the resource-poor countries. Less vaccine, less emergency facility, etc. So do any of the speakers have any advice for policymakers in this country? And let's take an example, Vietnam, for instance. So any of you have any comments for that question?
Well, look, throughout the pandemic, Vietnam's actually done remarkably well. I think the country can be proud of its response. Obviously, Delta has thrown a bit of a spanner, as we say. It's made things much worse and increased the number of cases and the number of deaths. But overall, over the last 19 months of the pandemic, I would say that Vietnam has responded quite well, and should be recognized for that. Inside a country, it's important to do what I said before, which is you have to distribute the resources to make sure that you minimize the number of deaths, both from COVID and from indirectly from COVID, because people are not getting other treatments. You also need to minimize the disruptions to essential things, prevent people from falling into poverty, continuing education. That's the main goals of distributing resources, whether it's vaccines or it's PPE or hospital services. And I think that's what's necessary to do. And the larger question, I think, of how we prepare our societies going forward from this, I would say that one of the most important things we ought to learn from this is that we are interconnected. We are going to need a global response. It's an unfortunate situation that we have a world now that has more antagonism rather than more cooperation, because what we need is cooperation and antagonism that prevents a worldwide monitoring system, a worldwide response system, and collaboration over developing those systems. It's a problem. And I think, unfortunately, people will die because of those antagonisms rather than have a response. But there's a lot of things we can learn from this, this crisis. I would say one other thing that I would recommend from looking at the countries I have looked at, having a crisis management team that has representatives from not only the ministries of health, but economics, education, and labor, very important for an effective response. Those countries that had an effective crisis management team at the highest levels of government with authority to make decisions, they did better than countries that didn't have such organized crisis management team. And let me say one last word, and I want to pick up on what Dr. Alta Schutte said, and that is implementation is absolutely critical. Countries that have effective implementation mechanisms do much, much better. And we need to train, not just for crises like COVID, but for general health problems, much better management of healthcare systems in all countries. And this is a problem that cuts across rich and poor. All countries need better management.
Yeah, that's great, because I just saw a question from the audience asking that we all understand the event like COVID-19 happen in the future maybe, so similar or other pandemics happens in the past. So how can we anticipate a similar pandemic in the future? What would we do to have some kind of like appropriate strategies for developing countries to prepare for that? So I think let's talk a bit about the technologies and data science in terms of responding to the emergency situation, and COVID-19 is just a very, imminent threat and clear example. So do you want to comment on that, Professor Schutte?
Yes, thank you. I think if we think 100 years ago, roughly when it was the Spanish flu, and the data that we have available on that, compared to the huge amount of data that we have now, it is just a different world altogether. And I think in terms of the next responses, there's been so many lessons learned, whether it's vaccine development, whether it's implementation, whether it's collaboration, networks, and emergency responses. I think the world will be much better prepared going forward, and the role of data science is going to be immense, whether that is just in terms of data available to governments and ministries of health to make decisions, or whether it's changing data. When you speak about data science, it's also now a new world in terms of how patients are managing their own health. We all have more and more wearable devices that we carry around on our arms that create a huge amount of data. Now it's measuring temperature and other responses that, who knows, may even be able to detect fever, etc. So having all of this kind of interlinked in the future in terms of responses, there's so much to be done, and I'm sure many people are contemplating what are the best processes going forward. We can look at it from a global perspective, from a ministry level, but also from the individual patient's perspective. What is the access they would have available to them? And as with mobile phones, there are much more that can be done even in poor countries in terms of individual patient access to care and access to their own health knowledge. So I think data science is going to be very important in the next responses going forward.
Thank you. And I think talking about data science, there's a lot of exercise and project on projection and forecasting of the pandemic, not only at the global scale, but in each countries. So is there any good example of the group that doing well in the forecasting that supports the government to respond to the COVID-19?
There may be too many groups doing forecasting. I do think forecasting, again, if we compare this to the 1918, 1919 pandemic, forecasting is one of those areas that literally did not exist 100 years ago. Now we have many, many different and competing models, and they're absolutely important for making predictions about the kind of resources you need, where you need those resources, where things are going to explode. Even with all of that ability to make models and make predictions, they all depend upon underlying real life, real world data. And what you see, again, I think Israel is probably the best example, systematic real world data on every single person in the country. What better could you have? You understand how the vaccines are working, what happens when people aren't vaccinated, who gets sick. I have to say, one of my biggest disappointments in the United States is we have not created that kind of infrastructure. I recommended, the NIH should have put in an infrastructure where we could follow millions of people who got vaccinated, understand who gets sick. where we could figure out who's in the hospital every minute, where when someone tests positive, we could offer them interventions to be in a randomized trial. We would conclude, if we actually did that in the United States, and say only 2 or 3% of the people who tested positive were willing to enroll in a trial, we could conclude a trial every 2 days. We could have tried hundreds of different treatments very, very rapidly, figured out what worked and what didn't work. Instead, we had a totally disorganized, fragmented system where each academic researcher did his or her own thing and nothing. I mean, we had very, very little to show for all of that in our therapeutic area. This is an area, the therapeutics area is a place where we really need to look to Britain, real world data. We need to look to Israel as models for that. And I think those are good models that we need to replicate around the country.
So Dr. Alta, can you share some perspective from Australia, maybe?
Yes, I fully agree. Here in Australia, there are several different groups that do modeling, and the government is always looking at the sort of data. And sometimes the modeling is wrong, and then you go back and change it with the Delta, for example, when that really entered, it really changed a lot of trajectories that were originally planned. But nevertheless, I think the challenge remains in seeing the wood from the trees. When there is such a massive amount of data out there, what to do with it, how best to strategize in using that going forward in terms of decision making. And that's where different governments follow different strategies, as just said. So I think, again, I hope there's a very steep learning curve on what worked, what didn't work, so that when there are similar or future pandemics or similar crises, it could be different types of crises, how the data that we collect, this massive amount of data, can be simplified for easier decision making, as clearly when there's so much out there, it's very difficult to really see where to make the decision on.
Thank you. I have another question from the audience just recently. So Dr. Emanuel, is it true? It is true that many fundamental biomedical research would take decades, as you said, to lead to impact, and developing countries need to start investing in basic science. But are there any low-hanging fruits that new research from developing countries could provide immediate impact? And if so, what should be the research strategies in global health for new universities like VinUni from Vietnam?
Well, it's an interesting question. I'm not 100% sure I'm the perfect person to answer that question. But one thing I think is important for a place like VinUniversity is to actually roll out interventions and demonstrate, going back to the comment that both of us have made about implementation and implementing major interventions and show how they can be effectively implemented throughout the population. You know, if you look at the United States, the single best intervention in terms of reducing mortality over the last 60 years in the United States has been hypertension control. We got lots of cheap drugs, lots and lots of cheap drugs. And yet, I will say in the United States, hypertension control is, you know, at best grade C. I don't know what the equivalent is in Vietnam, but it's not an outstanding performance. Maybe 60 or 70% of people who have hypertension have it diagnosed and well controlled. 70% is too high. It's probably in the 50 to 60% range, right? Even though easy to measure, easy to treat, we should be up at 90%. I think demonstrating how you can do that on a mass scale and making sure prevents heart disease, stroke, kidney disease, and many other problems. And I would think that implementing that, if you're asking what area going forward over the next 20 or 30 years is going to be a major area where interventions are going to be important, I'll tell you, I think mental health issues are probably number one. While we were shown very nicely the number of deaths from various diseases, that left off mental health issues. But if you look at Dolly's loss, mental health comes in at number 4 in the world. It seems to me that one of the things COVID has made clear around the world, and one of the things that we're going to all learn a lot about, is we need to treat mental health better, and we need to find root causes of mental health and better treatments for them. And so if I were investing now, that would be a major focus of my investment. I don't know whether that's low-hanging fruit, but it's long-term guaranteed to be important.
Yeah, thank you. So speaking about the mental health and the non-communicable diseases, I think if we pick 4 countries that we are very familiar with here: US, Vietnam, Australia, and let's pick South Africa, so 4 continents. And if we have a closer look, we will see that ischemic heart disease and stroke are among the top 5 causes of death in all 4 countries. And then lung cancer, COPD in 3 out of 4 countries. And all of those health problems are actually non-communicable diseases. And if we look at the risk factors, quite similar issues in these countries, like high body mass index, or obesity, high blood pressures, as you said, and high fasting plasma glucose. So given the fact that we are having quite similar patterns of burden of disease and risk factors, how can we develop collaboration and partnership to solve such problem? How about I address this issue, and I hope that Professor Schutte can discuss on this.
Yes, thank you. That is really the focus of my work, is in terms of the field of high blood pressure. So high blood pressure is the leading cause of death. And it really, second to that, I think tobacco is another thing. It's been on the cards for many years. It's old news. People are almost not interested even when you mention it, but still it's the central reason for death, contributing to stroke, heart disease, etc. And with smoking, the same for lung disease. So, and that is the major frustration, is there's medication. It's very easy to detect it, but in the world, more than half of people with high blood pressure are unaware of it. So there should be simple strategies, and that could be major. And there's been major organizations established just to do that, and they still struggle to get over that challenge of implementation. So I think these are low-hanging fruits. We have very cheap, very effective medication, and we need to find new ways. It's not always that molecular discovery that's going to change it. That's already been done many years ago. The challenge is to get it to the people and to find novel ways of doing that. And I think following old ways may not be the trick. We need to think in new directions. We need to involve not only, for example, general practitioners, but also nurses, community health workers, and other means to reach everyone, whether it's in a high or low income country. Even in the US, as it was said, and other high income countries, the rates of managing these diseases are very surprisingly poor. It could be done much better because the health systems would support that. But I think these are low-hanging fruits. It can make a major improvement in terms of quality of life and in terms of health economics for the country if these are treated effectively and with better implementation.
Yeah, thank you. So I think it is clear that we need to use technologies and collaborations. So is there any way that we can kind of like fast track the research so that we can better address those non-communicable diseases?
Again, I mean, if I were to say, first of all, I think we have a lot of, I think both of us have been saying, a lot of suboptimally used treatments today. And one of the things that research can show is what kind of deployment works better and works not better. In the United States, we call this implementation science. But I've often thought that the biggest impact we could do for the health of certainly low-income countries is get a lot more MBAs trained in supply chain and in implementing and deploy them in the healthcare system. I think that, and I'm not joking about that, whenever I travel to Africa, and I've done it many, many times, the thing that overwhelmingly hits you is how bad the management is of many things. And having good management is very, very important to having good healthcare. We in the United States have only just begun to learn this, not to implement this. I would say that the second thing that important research is on, ought to be focused on, as I mentioned, is unsolved problems. And I think I've already mentioned mental health as one of the unsolved problems. I think there are additional areas, diabetes and preventing diabetes formation. We understand about obesity, but I think figuring out how to get people to change their diets, and again, a lot of this is about behavior, is absolutely critical. I don't think the problem is necessarily one of collaboration on research. I think researchers are more than willing to if there are the resources there, and if they can see rewards to their own progress. I do think one of the things that's really important, and again, that Britain has shown so well in COVID, is collaborative research may be more important than individual investigator-initiated research. I know in the United States that's heresy, but I think the success of the British in this case has suggested that.
Yes, there's another question from the audience that worldwide, I think that we are now realizing that we need to live in harmony with the COVID-19. So how do you see the roles of science and technologies in helping us living in the new normal? And any suggestions for researchers or people in the universities in terms of educational and research activities? I guess this question is from one of our audience from faculty member of some universities. So how about that, Professor Schutte and Professor Emanuel?
Yes, well, I think there's going to be huge implications living with this, with a virus, because we need to, even with vaccinations, we see we will going to learn to live with it. And it has implications not only for the treatment and management, but in terms of mental health and all the changes in behaviors that we've seen now. Screen time, for example, screen time with everyone, adults, children throughout, and that implicates on mental health as well. I think it's really going to be quite a change to go back to a different world after COVID, because we're going to have to live with it, and we are going to have to cope with these behavioral changes. I think that's broadly applicable, not only in specific countries. Everywhere it's changed, and everywhere, whether you collaborate with the other researchers in other countries, it's been, you see the challenge in their eyes, the tiredness of sitting in front of the screen so long, and it has have other implications on health too. But I also want to mention, I think in terms of the research in this space, the communication between research bodies, researchers themselves and governments are very critical. Researchers are very open to collaborate with each other, as was just said, but it's often that communication and who communicates with government, what do they listen to, and when they make decisions, which is often the place where there's miscommunication and where strategies in countries have been problematic. It's going to be important going forward as well in that sense, living with a virus.
Yes.
I don't think we have any idea what living with the virus means yet. I think it's just that simple. You know, the virus is coming and going, and we don't exactly know why you get these surges and why they go away. Why, for example, did it go away in India? No major interventions, and yet, you know, Delta has not done in India what it did in Britain or the United States, just as an example. I do know what it would look like were we in a stable state. It would be like the flu. Now, whether we can be between vaccines and some effective therapies get it to be like the flu, I don't know. So I think I'm not sure what living with COVID looks like just yet. The other thing I would say is we don't have long flu. We do have long COVID. And if that is, you know, even 1% of the people who get infected, that is a lot of people, and it is going to be a big problem. We don't know yet the ramifications of that. And I have to say, of all the things, that scares me a lot. We got a lot of ACE receptors around the body, in the brain, in the lung, in the heart. You can have a lot of serious damage there, even if someone is asymptomatic from the infection. And I think we simply don't understand the magnitude of that problem. And, is living with it going to mean, every year, hundreds of thousands of people get this weird disease called long COVID?
Yeah, thank you. So I think we spent time discussing a lot about COVID and also about other non-communicable diseases as a huge burden of disease worldwide and different countries. So I think one of the comments, not a question, but I saw from the chat box from the audience is that the example of the high blood pressures and mental health stress that we can significantly address, and that would impact life of many people in the world through simple, community-based or public health efforts that would require, not a lot of like sophisticated technologies, but then with good coordinations and support and simple research, we can improve the health of so many people. So I think that's a great comment. So for closing, I would like to thank you so much, Professor Zeke Emanuel and Professor Alta Schutte, for taking time with us today. And I think we just kickstarted our monthly VinFuture's Public Dialogues series today with a healthcare theme: how is science transforming global health? And I think I learned a lot from you, and I'm sure the audience enjoy your talk and discussions. Still, I think we have lots of other questions that due to the shortage of time, we cannot address them all. But I would like to take this chance to thank VinFuture organizers and leaders. And of course, a big thanks to all of you, the audience, for today's discussion and participation. Thank you and have a great day or evening, all of you. Thank you and goodbye.